CataractCoach.com, iStent Infinite MIGS device, and phaco chop. This first month of fellowship is off to a great start. Now, at the beginning of the case here, trypan blue dye was used to stain the anterior lens capsule, but also to temporarily stain the trabecular meshwork to make the MIGS device easier. So there's a nice fill of viscoelastic, certainly a lot of cortical changes there, probably nuclear as well. Let's see that main incision here. You can see an attending is watching over this young doctor very carefully. That looks like a pretty nice looking incision. I'll take it. I like the position of the incisions as well. And now, of course, angling the head away from the surgeon and bringing the microscope towards the surgeon to get in the appropriate position to put on the gonioscopic mirror. And so here comes the gonio prism, and you can see the eyes in pretty good position there. And the surgeon is going to use this iStent Infinite. So this has 3 little micro bypass devices. You can zoom in here to the angle, see nice angle anatomy, very easy to see. And you also notice at the beginning of the case that the main phaco incision wasn't too much in the limbal vessels because you don't want to have that blood in the interface clouding your view here as you use that gonio prism. So there's one device being placed, and again, here comes the same device, can be triggered again for the second one, and then maybe like a clock hour away, a third one. So looks like these are about 1 clock hour away from each other. 1, 2, 3, these devices. Oh, where's the third one? Coming up soon. You can reposition that mirror if you need to, and you can place these devices. These are placed now, obviously, at the beginning of the surgery. So first these devices are placed, and then cataract surgery will be performed. So there you go, 1, 2, 3 devices, all appropriately placed. Now, if you're a young doctor just starting your fellowship, you've already realized that a lot of times your fellowship preceptors will have you do a case while they watch. And that's how they gauge what level you're at. What did you achieve in residency? So ideally, you achieved a lot in residency and learned a lot, so when you come to fellowship, you can learn even more. So there you go. A little bit of bleeding there from one of the sites. That's perfectly fine. A little more viscoelastic to make sure you have a nice fill. And let's see the rhexis. Of course, we have sped up the video to 2x. That's perfectly fine. We just want to give you the maximum amount of learning here. So it's interesting here to see that, okay, there are the forceps. Looks like they were slightly bent, so the surgeon is adjusting them to make sure they work better. And nice, no need for a cystotome. I agree. Forceps are marked off at 2.5 and 5. I like that idea. And now let's see that rhexis pivoting in the incision. Very nicely done. And that looks like a nice secure rhexis. Of course, aiming for about a 5 millimeter rhexis here. And the technique is excellent. So surgeon shows very good control here. And let's finish that up. That looks beautiful. That's a 5 millimeter rhexis for sure. Now let's watch the case carefully. Let's figure out where we can offer some advice for improvement. So using a specialized Chang cannula here for some hydrodissection. A little bit more here. And I like the multiple quadrants of hydrodissection. And look at that nucleus. It definitely spins. And now let's see what the next step is going to be. Here, as you know, I like to place an extra little small aliquot viscoelastic to protect the central corneal endothelium, but of course not needed here. Cleaning up the anterior cortex. And let's see the technique here. Are we going to do phaco chop? So here's the chopper going in, and looks like a horizontal chop going around the lens equator. And propagate that chop. Yeah, don't stop now. Keep propagating it. Make sure those pieces are split apart. Here's another quadrant being chopped. So now you got a free quadrant that can be brought up. And of course, things are moving fast. You can use the YouTube button down there and put the video at slower speed. And then you'll be able to watch this at 1x. And so here's the other half, and then a nice chop. So certainly very adept at chopping. I like how the eye staying at primary. You see those 4 lights on the center of the cornea. That's the Purkinje image from the anterior cornea. And those pieces come down pretty easily. And let's see, is the chopper going to protect the bag? I do like to have a chopper there to protect the bag. And now phaco probe in the eye. And I like that too, not letting the eye collapse. That's a nice move too. So injecting with one hand some BSS while the probe is being removed just to make sure you keep the eye inflated there. You can see the architecture of the incisions look pretty good. Nice, good, appropriate tunnel length. Architecture looks pretty reasonable from this view. Here comes the IA probe. Let's clean up the cortex. Now, this is obviously a glaucoma patient, so probably your best choice lens is going to be a monofocal lens for the patient as opposed to a trifocal or other design. And now cleaning up the cortex pretty efficiently. Maybe a little capsule polishing going on. Let's see. Clean up that cortex. There you go. There's the polishing. A little bit of polishing with the very light suction. You can control that with your foot pedal. And that looks, again, very nice and clean. And so far, I don't have a whole lot of suggestions. This is done very nicely. Yeah, maybe I could nitpick about the couple of the eyelashes there, but those are not really causing much of an issue. There's that fill of viscoelastic. I like that as well. Here comes the new IOL. Going to go in the capsular bag. And that goes in almost all the way. Get that one dialed into position here. One haptics outside the eye, so that can be dialed in. Very nicely done. And now take out the viscoelastic. Wow, beautiful rexus. And now take out the viscoelastic, hopefully going behind the lens also. I like that technique to go behind. Are we going to do it? No, not so far. So there's my big bit of advice for you. Please go behind the eye wall and remove the viscoelastic from behind the optic. That's an important step of surgery, especially when you do like a toric lens so you don't have any misrotation. Seal up the incisions here at the end of the case. Wow, beautifully done. Great work. Keep it up, and definitely send us more videos. Thanks for watching.